and how do we rehabilitate these patients. Okay, so marginal mandibulectomy, as we all know, is a surgery where we remove mandible either as a part of margin where the tumor is abutting mandible from either the cheek or the ventral surface of the mouth or tongue, or for a superficial alveolar erosion. This is a very famous article which all of your students must know about how the tumor spreads to the mandible. So I would like to start from there. So can I have Dr. Anuja ma'am to please tell us about various ways in which the tumor spreads to mandible and what are the most important ones that matter in these cases?
Thank you, Vidisha, for providing the slide, which actually states there are 7 ways of tumor infiltration. So you can read about this all 7 approaches, how the tumor gets into the mandible. But the most important thing you have to remember how we reach this all routes of invasion into the mandible. So initially it was thought it is the periosteum which is a problem and you need to remove it for every case, and then we reach the concept of a point of abutment theory, which is the most important theory nowadays which we follow. So it is not always the occlusive surface from where the tumor gets into the mandible, but that is the commonest site. But the most important thing is the point of abutment that we have to remember. And depending on the point of abutment, we decide whether we have to do a marginal or we have to do a segmental mandibulectomy for the patient.
Right. Thank you, ma'am. Dr. Abhishek, apart from this point of abutment, any other factors that we would like to take into consideration when assessing a case, whether it is suitable for doing a marginal mandibulectomy or it should go for a segmental? We would like to elaborate upon that.
Yes, two important factors. Is there any soft tissue disease on the lingual or the buccal of the mandible, which is known as paramandibular disease? Second is the patients, and third, a relative contraindication would be as the patient received prior radiotherapy. So, prior radiotherapy, dentate versus edental status, and soft tissue, which is involving the lingual or the buccal cortex of the mandible. Abutting the lingual or the buccal cortex of the mandible, so-called paramandibular disease.
Right. So the most important thing, like you said, sir, is vertical extent, height of the residual mandible, extent of paramandibular disease, which is a very clinically important decision to be made by the surgeon, and also the horizontal spread of the disease, how far away the tumor is from your mandible. Right. So, Dr. Rajdeep, do we have him here? Hello?
Yeah, I'm there. I'm there.
Yeah. So, sir, could you please tell us about different types of mandibulectomies, which are the common types of marginal mandibulectomies done and which are a little uncommon ones?
Okay, so the most common marginal mandibulectomy that we come across is where we are removing the margin close to the tooth, the upper part of the mandible. Now, this can be from where the coronoid starts to where we need to remove, like the entire extent. It can be in the anterior, it can be in the lateral part of the mandible. There are the other types, like we have the oblique and the vertical ones. Now, the vertical one, there is also a paper by the Tata group about the outer part of the mandible being removed, and we have the lingual plate of the mandible being removed. Sometimes, rarely, we will also need to do a rim resection of the mandible from the inferior end when the nodes are stuck to the mandible.
Right. That we would call it as a reverse marginal mandibulectomy.
Reverse marginal mandibulectomy.
Right, sir. So my question in general to every one of you, we do all horizontal marginal mandibulectomy very frequently, but how do you go about deciding feasibility of doing a oblique or a lingual plate marginal mandibulectomy? Any clinical pointers to decide about that? So how do we decide whether
More
a
than
candidate is
feasibility,
suitable?
I would.
Yeah, please.
Hello.
Yes. Please
Yeah,
go ahead, sir.
Dr. Dushyant here.
Yes, sir. Please go
So,
ahead.
so Vidisha, that basically the decision of your marginal mandibulectomy comes when there is a cortical erosion of your bone. Now, when you are thinking of an horizontal marginal mandibulectomy, usually it's an alveolar disease which is sitting on inner and outer side of the bone, which is the lingual side as well as the buccal side of the bone. At that point of time, you want to have margins on both the sides, where you go for an horizontal marginal mandibulectomy. You can do a slightly oblique marginal mandibulectomy when the disease is at either of the side. If it is at the inner side, you take more bone on that side. The idea is to keep more bone stock, sturdy bone stock, to make your marginal mandibulectomy stable. Equally, same, the vertical marginal mandibulectomy is usually used for a limited disease of floor mouth, which is abutting or coming near to the inner cortex of your mandible.
Right. So I'd like ask Anuja madam, how do we decide between whether we need to do a marginal mandibulectomy, or we can just away with removing the gingival mucosa, which is commonly called as mucoperiosteal stripping? How do we decide upon that, whether a marginal mandibulectomy is required for a buccal mucosa disease, or we can get away without doing it?
So why we do a marginal mandibulectomy is because the tumor is approaching the mandible. So it is close to the mandible, or it is reaching the mandible, or superficially involving the mandible. And in this situation, you will again the line of abutment you will evaluate. So you will do when the tumor is far away from the mandible and you can get an adequate margin on the mandible, then you can just do a periosteal stripping. But if the tumor is abutting or coming very close to the mandible, you will require some kind of a mandibular resection so as to get that medial margin adequate for your resection. There you will do a marginal mandibulectomy. So
Right,
tumor approaching to the mandible or very close to the mandible where you cannot achieve an adequate margin, there you will do a marginal mandibulectomy. If you have adequate margin with mucoperiosteal stripping and line of abutment tells you that you are very far off and you can take care of all the soft tissue in all 3 dimensions, please go ahead and do the mucoperiosteal stripping. Then you will not require a marginal mandibulectomy.
Right, right. Thank you, ma'am. So now that we have established the ways of tumor spreading to mandible and what is the line of abutment, what are different types of marginal mandibulectomy, my next point here is how do we assess the radiological spread of the tumor for suitability for marginal? So, Dr. Abhishek sir, can you please tell us about different modalities which are available for assessing adequacy for marginal, whether CT, MR, any other modalities, and which is the best?
Vidisha, can I just tell something about this
Please,
vertical
ma'am.
and oblique? Just a
Yes, ma'am.
point about,
Please,
if you
ma'am.
can just go to that slide.
Yes, please, ma'am.
So the thing is, the rim marginal mandibulectomy is the most commonly performed, and all the retrospective data about the control, survival, everything is about the rim marginal mandibulectomy. You do a oblique or a vertical for a limited disease and mainly for the floor of mouth because you wanted to take care of the disease which is coming closer to the mylohyoid muscle and abutting. That's why you do a oblique marginal taking a lingual plate. Doing a vertical marginal or oblique, you actually take care of a major part of the mandibular bone. But said that the inferior part of the mandible is most strongest, as we know from the cadaveric data, and the more 50% of the cross sectional of the mandible is in the inferior cortex. That's why you leave behind the most important part of the bone uh, uh, with the patient so that you don't have a pathological fracture. Other thing is the all the accessory foramens are there in the upper part of the mandible and very less on the lower part. So the route of entries are you are taken care when you are removing the upper part of the rim of the
Rim of the
mandible. So
mandible,
that
right.
is the whole idea why we do a marginal mandibulectomy and different types and all that.
Right,
Yeah.
right. Thank you, ma'am.
Thank you.
Yeah. So coming now to the radiology, Dr. Abhishek, could you please give us some pointers about which modality to choose and which is better to assess spread involvement of bone by the tumor?
So, contrast CT is the modality that we all from the tongue, and the bone cuts of the CT scan will also tell you about the involvement of the bone. Now, which in particular you can have an oblique reconstruction, and which will tell
Right.
you about the exact extent of bone erosion. You can also do a 3D recon and then rotate the image as you want, and then calculate the depth of erosion. Now, of importance here is that uh, if you are contemplating marginal mandibulectomy in superficial bony erosion, then remember that there should be enough.
I think we lost the
Yeah, even
voice
I
from.
cannot hear. Yeah, even I
Mhm.
cannot hear. Maybe there is some connectivity issue. Or Dr. Abhishek, can you hear us?
Yeah. Sorry, I got disconnected.
Okay.
Can you hear me now?
Yes, please. Thank you.
Can you hear me now?
Yes. Maybe
Yes,
the
sir.
connection is
Yeah.
really lagging.
So, yeah, I'm sorry. Take into account three things. One, the remnant height of the mandible should be enough to account for 1 centimeter of margin, 1 centimeter of remnant bone, and maybe 1 or 2 millimeter of bone loss while you're cutting it.
Right. So, as rightly said by Dr. Abhishek, CT scan, a multi-detector CT scan with oblique reformatting is one of the best modalities that you can have for assessment of buccal mucosa lesions going on to the mandible. For the benefit of students, they should know this article in which multiple modalities were compared to assess the efficacy for involvement of the tumor, which is OPG, MDCT, DENTA scan. And this study found that MDCT was the most accurate imaging modality to decide about the involvement of the mandible, right? So again, now we come back to our indications and contraindications. The absolute contraindications will be gross mandibular erosion,
Vidisha,
paramandibular. Hello?
Vidisha, can I just interrupt you, please?
Yes, ma'am.
So the previous study, what you have shown in that, there is no MRI, right?
No, there is none, ma'am, because those were for a buccal mucosa cancers where we would usually do a CT scan.
Yeah, so the thing is, if you look at the bony involvement, the MRI is also a good modality where you have a high specificity and sensitivity, what you have it in the CT scan. The most advantage what you get with the CT scan is more specific. With MRI, what happens that the medullary edema can actually give you false positive result when you do a MRI. So MRI can give you a high result, but it has to be cautiously read, and it takes longer time and other things. And the CT scan is friendly with the surgeons to read about and shorter time also. So those are the advantage. If you have a floor of mouth disease, then I will do a MRI. I will not look at the CT scan. Maybe
Right,
if I have a choice of only one investigation.
right.
And when
Point
it's
taken,
the
ma'am.
fat erosion, then I will do a MRI maybe.
Point taken, ma'am. Completely taken. So this
Also,
is to summarize. Yeah,
if the
please.
tumor is close to where the mandibular nerve is exiting, then this is one point where I would want specifically to get an MRI done to look if the tumor is invading via the mandibular nerve opening into the marrow of the bone. Even if on CT it may not show a bony cortical erosion. So on specifically if tumors near the mandibular foramina, I would want an MRI.
Right. Very good point, Dr. Rajdeep. Thank you.
Also, Vidisha, I think in the patient who are partially edentulous, that is also possible in our set of patients where there is a poor dental hygiene, to be a little extra cautious. As it is rightly mentioned, we will like to get an MRI done, though it may overestimate, but it will save us from a lot of problems intraoperatively.
Right, exactly. So now that we have gone through the indications and assessment of the patient for marginal mandibulectomy, let's come to the surgical tips and tricks. So I'd like to ask Dr. Dushyant, what would be your incision planning for performing a mandibulectomy? How would you decide about which incision to place, per oral versus cheek flap? Which kind of incision? Can you give us some pointers?
So, Vidisha, basically, it will depend upon on which part of the mandible you are going to perform your marginal mandibulectomy. If the mouth opening is good, that is There is no submucous fibrosis. If the resection is anterior, let us say central large tumor or tumor which is in the premolar area, you can do this marginal mandibulectomy with various maneuvers, intraorally also. Encroaching to the angle mouth, and your margin is going to compromise the blood supply around the lip, then you will go at the angle mouth, because you don't want your angle mouth vasculature to be disrupted and putting a midline lip split, jeopardizing your lower lip.
Yes,
So,
exactly.
so where your tumor is, mark it first, your resection, and accordingly you plan your lip split incision.
Right. Thank you, Dr. Dushan. Another point I would like to say is about the involvement of the skin by the tumor. If there is any possibility of requiring to excise the skin for your third dimension, it is wise to probably take an angle split incision, which maybe easily can encircle the involvement of skin without jeopardizing your lip blood supply.
Agree.
Yeah, so Vidisha,
Yes.
I totally agree with your point about the looking at the skin. So if the skin may not be like totally ulcerated, but you might require a skin excision. So always mark, whenever you are doing a oral cavity cancer patient, always mark first the how much skin you need to excise as your third dimension, and then you place your approach to your tumor. So you can do a safely angle split for most of the tumors, but midline is very selective patients, you will do it. And you have to take care not tumor approaching to the, but you have to think about where the incision you're going to place. The incision, tumor might be posterior, but your incision, because of the leukoplakia, is going to cut till the angle of the mandible, then you should not take a midline split then.
Right. And for the students in the audience, I would like to say that it is possible to do a marginal mandibulectomy by raising a cheek flap without splitting lip, which is called as a bucket handling. Many of you might be aware of it, but this requires a very good understanding of how your third dimension is going to be taken. So if you are doing this surgery in the beginning part of your career, whether you're not done many cases, I would recommend that you go by traditional approach, perform a lip split, either an angle or midline split, take adequate margins in the third dimension, and then perform your surgery. Once you have done a fair number of surgeries, you are aware of how to take a third dimension without splitting lip, then attempt your bucket handling so as to not compromise onto your soft tissue margins. So the next point, Dr. Abhishek, would you like to give us some important tips or precautions while doing a marginal mandibulectomy? What to do, what to not to do while doing a marginal mandibulectomy, and what sort of instrumentation is better to be used while doing a marginal mandibulectomy?
Okay. First is the shape of the marginal mandibulectomy. The edges should not be right angle. So it is described as cano shaped or boat shaped, or consider it as an arc of the circle. The idea is that the masticating forces should not fall upon the remnant mandible at 90 degrees. They should be evenly distributed. Otherwise, this may cause a pathological, I mean, a traumatic fracture.
Fracture.
So that's
Right.
one. Sorry.
Go ahead.
Yeah, that's point number one. Point number two is the height of the remnant mandible. The remnant mandible should be at least 1 centimeter in height, so that you decrease the chances of once again causing a fracture. Third is the vascularity on the of the mandible. Now remember that the mandible will be supplied by its nutrient foramina and also by the periosteum from the buccal and the lingual aspects. So you cannot strip the mandible of all of these blood supplies. Otherwise, that segment of the mandible will become avascular, and there is a chance of osteoradionecrosis if post-op radiotherapy is to be done. The fourth thing is margin. Obviously, if there is bony erosion, as I said in a previous comment, there should be your marginal mandibulectomy should be done only if a 1 centimeter margin uh, uh, can be achieved. Now, regarding instrumentation, ideally is to have a saw. You can use a sagittal saw or a reciprocating saw. Be very careful as you curve, because the saw is not the perfect instrument to curve. But with a little practice and with a little back and forth movement, you will be able to get that curve. If instrumentation such as saw is not available, you can use fissured burrs. Now, remember that this is not the ideal tool for doing a marginal mandibulectomy. But if you, not all institutions will have a saw, you can use a fissured burr. You can use a 1 millimeter fissured burr. You can do what is known as postage stamping, so that you have marked the marginal mandibulectomy and you have done holes along the proposed line of marginal mandibulectomy using a drill bit, and then you can join these holes using a fissured burr. But remember, the ideal instrumentation would be a powered saw.
Right. And also any experience with the piezoelectric, because this is a new instrument. Maybe the maxillofacial colleagues are more well versed with using a piezoelectric saw, and in certain cases, maybe for an intraoral marginal, it might be a good instrument, but only if, of course, you have availability of the instrument.
Yeah, so I have used it only when it was demoed in our hospital, and I found it a little slow. But yes, it is a precise instrument.
Right, exactly.
Yeah, I agree with Abhishek. I have also used it. It takes many years to cut the mandible, but if you're not doing a cheek flap and it's a small lesion, you can avoid a cheek flap for the patient. It is a good kind of instrument, and it gives you a very precise kind of excision of the mandible without doing the more morbidity for the patient. So even the reconstruction and everything becomes very easy for the patient. You avoid a scar for the patient.
Right.
True.
So this
Yeah.
is the article Dr. Abhishek was referring to about the biomechanical analysis of how the forces are distributed over on the mandible. This is just for the interest. It's a cadaveric study where they examined the fractures of the mandible at different residual heights. And they found that when the height of residual height was more than 10 millimeter, the reduction of bite forces was better, and the height more than 10 millimeters was recorded based on this cadaveric study, which we follow currently. So next, now we
I think Vidisha in 87 articles also actually said the same thing on the fresh cadaver, where incremental weights they have put and they have
put on the
checked
various
on
heights of the mandible.
same
Yes,
conclusion, but this is the latest and very fancy photograph it has got. But
yes,
the
I just
87
thought
was
the residents might just benefit in their exam by telling fancy things.
yeah.
Vidisha,
But the backup paper is the old paper where the
Right.
marginal was based on, and it's again a cadaver study on the mandible, and they kept on doing the incremental osteotomies and then looking at the how much force of chewing they will have. So it's a gauge, basically gauge
Dr. Vishnu,
analysis.
you were saying something?
yeah, Vidisha, I will like to make one point,
Yes.
especially for the youngsters, is that we time and again say that 10 millimeter margin, 10 millimeter margin. Now we have to keep it in mind that 10 is minimum. So when you are doing a marginal mandibulectomy, where the disease is just abutting your mandible, you can actually take in a dentulous mandible a larger mandibular remnant. Larger the mandibular remnant, better is the stability of mandible. So,
Exactly.
so never aim that you will just keep a 10 millimeter, because uh, anything which is more than 10 millimeter is definitely going to benefit the patient, not only for the robustness of the mandible, also for your dental guys who are going to make the patient dented again by putting the implants.
Right.
So if you can preserve the larger height of the mandible, better.
Right. Exactly.
Yeah,
Good point.
good point. And another point, Dr. Vidisha, would be to factor that there will be some bony loss while cutting. Even if you're using a saw, anticipate a 1 millimeter loss at least.
Totally. Yes. Good point, sir.
And
So,
one more point about doing a vertical mandibulectomy, like a lingual plate or a buccal plate. So you can only do this procedure only in the body part of the mandible because you have a medullary cavity. You can't do it in the anterior segment or a posterior segment. So it is only feasible in the molars areas where you can do the vertical marginal mandibulectomy, like a buccal or a lingual plate, because you had to extract the teeth and then you can do the vertical mandibulectomy in that sense.
Right, ma'am. Right. So now coming to the reconstruction. So how do we close these defects? What kind of modalities we can use? Just a primary closure, any local flap or free flaps? So where do we use what? Dr. Dushyant, any pointers about this?
So your reconstruction will depend upon many aspects. One is including what is the size of the defect you have created. If you just remove the alveolar tumor and you have unhealthy mucosa in a patient where there is no submucous fibrosis, where you can bring in the mucosa. So a limited resection with unhealthy mucosa, you can do a local flap, which is an advancement flap, which is a primary closure also you can do. In most of our patients, they are submucous fibrosis, and the marginal mandibulectomy is usually used in a GB sulcus tumor, which is encroaching your mandible. So you lose a lot of mucosa, which is not usually be possible to be replaced locally. So you can harvest a local flap, that is a nasolabial flap or submental flap or a platysma flap, or you can do it with any local regional flaps or a free flap.
Right. Thank you, sir. So, in the interest of time, I will skip this point on the oncological safety. Suffice to say that there are multiple case series from the hospitals which have conveyed that there is cause-specific survival of over 80% with the local recurrence rates up to the range of 10 to 11%. This is one very old article by Dr. Pradhan, which is said of a 79% local control rate with marginal, but it guards against the exact case choice for doing a marginal mandibulectomy, where they say that a deep infiltrating lesion in the lower GBS, it might have a paramandibular infiltration, even though the mandible is radiologically uninvolved, and where you might end up with a positive margin. So the students should please remember this. Your assessment of the tumor spread in a vertical and horizontal dimension is very important for your safety of doing a marginal mandibulectomy. So now coming to the complications. So what complications do
So
we
Vidisha,
anticipate on
just
this
a point.
surgery? Yes, ma'am.
So Vidisha, just one point. So as you said, the soft tissue component is very important. So I would also like to say the prognostic factor, the how's your soft tissue margin in a marginal mandibulectomy is important factors. So if you have a frozen session, you should take care of that soft tissue margin on table, because it's not possible to have a mandibular margin on table, because you have to have a decal reports, then only you can comment on whether you are good on the margins of the bone or no. So these are the indirect methods which you can do it intraoperatively. You can say send some scraping, or you can send the soft tissue, and that will guide you that you are good on your soft tissue margin. These are the most important things which actually takes care of the local control, apart from the prominent pattern of invasion, whether a tumor, what is the thickness and all that. Irrespective of all that, the soft tissue is the most important thing, which is the most important part for the recurrences and the control rates.
Right, ma'am. So
So
now,
Vidisha, one point which I will like to make in concordance with Anuja, and especially for the youngsters and students, is that in the zest to close it locally, don't compromise in your soft tissue margins while doing marginal mandibulectomy.
right,
Keep it in mind. Your marginal is not a marginal resection. It has to be a good resection. So have good soft tissue and mucosal margins. Don't rely on primary closure. Always have a backup.
right, right, sir.
I
So
totally agree.
most common complication now we come to of this surgery, apart from immediate surgical complication of infection, OC fistulas, most worrisome is a pathological mandibular fracture. So, Dr. Rajdeep, could you give us some pointers as to what things we should do to avoid pathological fracture in the post-op period, and what are the risk factors?
So, starting like the instruments that you use, preferably use the saw or like what Abhishek Vaidya has pointed out, use the postage stamp method. So that goes in a long way to prevent surgical fractures. Then you should not have, like Dr. Abhishek again pointed out, not have sharp corners. You should have it like a board shape or cano shape, so that the forces of mastication get distributed evenly, and so fractures can be avoided. And then finally, you should have a good residual amount of mandible from the lower rim possible, so that when the bite forces happen, these things can be avoided. So these, like what all we have discussed, they are basically to prevent the pathological fractures only.
Right. So there are certain studies which reiterate the same points which Dr. Rajdeep has said. So this is one of the interesting studies which have told that there are higher chances of osteoradionecrosis when the patients are receiving concurrent chemoradiation with the radiation doses more than 60 and the patients who have been smoker. Also, this study, which is a 23 recent study, it says that the chances of ORN are more likely in a mandibulotomy as compared to marginal, but this could be a bias because this is a very small cohort and the patient numbers are unequal. Another important study, which is a very interesting study, which you all should know, this looks at other risk factors, which are for mandibular pathological fracture. So this talks about a mandibular body height preservation ratio, that is the ratio of the mandible resected versus left behind. So if the ratio is more than 0.3, if there are more than 20 remaining teeth post-surgery, and if inferior alveolar canal exposure has occurred during marginal mandibulectomy, so these are high risk features which could lead to post-op fracture in these patients. So these people also, this also said that patients who had prosthetic teeth in the remaining jaw are likely to have more fractures because they have stable occlusion and strong occlusal forces which could fracture this mandible. So this is an interesting study which has come recently, which gives more pointers such as chemoradiation, height of the dentate mandible left behind, and dentition of the residual mandible. So these things also should be looked into. Any other pointers would like anybody like to tell, Dr. Abhishek, Dr. Dushan, to prevent pathological fracture?
Yeah,
Any surgical
yeah.
things?
So I've seen some surgeons use a recon plate after a marginal mandibulectomy. If your
Right,
technique is
exactly.
correct, if your
Hmm.
technique is correct, if the shape is correct, if the remnant bone is adequate, you don't need to do that. In fact, it will increase your chances of ORN and ORN. So that is one thing you should avoid. The other thing, as has come out in the study, is, as I said, the three ways the mandible receives blood supply are from its periosteum of the buccal, lingual aspect, that's two, and from the nutrient canal, which is the inferior alveolar nerve canal. So if you're raising a cheap flap, your buccal, cortical, periosteal blood supply is already gone. So always try to prevent the loss of the or the exposure of the inferior alveolar nerve canal and the loss of the blood supply from that part. So
Right,
that is an important thing.
right. So this study also says
Vidisha,
that, yes,
yeah, Vidisha. I will say that the weakest
Well,
part of the mandible will be
yes.
at the third molar.
right,
Uh,
exactly.
Anatomically, if you see at the antegonial notch, the mandible becomes the thinnest. The last molar, once you do a marginal mandibulectomy at that area, you almost have non-existent inner cortex. So your mandible is barely on your outer cortex, and if your measurement is not good, then you can be less than 1 centimeter at the antegonial notch and your marginal portion. So whenever your marginal is going to go to your last molar, be very careful in considering that.
Right. And also, this is the commonest site where intraoperative fractures also will happen when we don't have availability of instruments such as reciprocal saw. We are doing with a maybe micromotor. We are tempted to use some small amount of chisel and mallet, which I would guard everyone against. This is the site where a fracture would happen intraoperatively also. So that I
Exactly.
always tell my residents not to be tempted to just take a chisel and mallet and try to take out that last part of marginal. You will definitely have a fracture on your hand. So please be guarded against
Yeah,
this.
Vidisha. Yeah, so I agree totally that be patient till the end, till the specimen comes as a nicely in a boat shape. So just a point about how to avoid the osteoradionecrosis. I feel we underestimate the defect and we try to do the defect with the good soft tissue margins. And when we reconstruct, we use some small flaps for the patient. So we should be judicious to use a free flap so that you have enough of a soft tissue cover over the mandible, so that that mandible can withstand the radiation toxic effect, so that though you have preserved the inferior alveolar canal, the blood supply, which is one of the thing where the mandible actually surviving, that will be prevented, and your mandible is not exposed, because when you are doing the cheek flap, you will have a very less tissue in between the mandible and the skin. So the point should be taken that you select the patient properly. Don't overdo a marginal mandibulectomy just because you wanted to save the mandible. If you are not happy, maybe a segmental is the choice for that patient. So you have to do a proper selection and a proper reconstruction for the patient.
Right. The good soft tissue cover after surgery is utmost important to prevent necrosis of the mandible after radiotherapy. Right. So now, coming to the last point, how do we rehabilitate these patients dentally after marginal mandibulectomy?
Okay, dental implant
Pardon me, somebody is speaking. Can we mute the mic? Maybe some participants' mic is open. Yeah, thank you. Yeah, so what about the rehabilitation after doing a marginal mandibulectomy? How do we do dental rehabilitation? Dr. Dushan, Dr. Abhishek, any words on this?
Yeah. So dental, implants are feasible if the remnant height is enough. You can have long implants. We haven't done many, but these are feasible. Um, some of my patients who do not have a bulky flap have received partial removable denture also. But that is in my limited experience. Apart from that, I haven't had much experience with using implants. I've only recently started doing that.
Yes, and for the partial removable denture, other factors such as having an adequate sulcus and having a particular height of the mandible would also be important, and also other teeth also should be stable enough to support a removable denture. Those all factors also should be considered.
Absolutely. Yeah.
Dr. Krishnan, any pointers on this?
So whenever you are using implant, you are actually trying to reconstruct or give the teeth up to first molar, maximum to the second molar. It is especially very useful for the central arch defects where your structure of the remaining mandible is wide and very robust. So you can put multiple implants, around 3 or 4 implants, and do a good central arch rehabilitation. But as you go posterior, it becomes a bit difficult for your implantologist to put implants.
Right. So there are isolated case reports where they have recommended a fibula over marginal for placement of implants, but it might not be practical in all centers, and it's only anecdotal a few case reports. So this is something I just came across a case report of rehabilitation of mandible after marginal using basal implant reconstructive prosthesis. These are longer implants which have a special arrangement for the implant to stay in a marginal mandibulectomy. So these case study claimed 100% success rate. Again, this is from a single center and may not be widely replicated. And they have claimed that there was a 100% success rate of their implant even after 16 months of follow-up. So this is one of the ways a patient can be rehabilitated, which could be a possibility, is what all you guys need to know.
So another important point, if you're using implants, is the timing of the implant. If you're anticipating radiotherapy, then the timing of implant is very important. Remember that this bone already has a less height and there is a high risk of osteoradionecrosis. So I would delay the implants.
Right. So this is a maybe
just a point about giving implants for a patient who has underwent a marginal. If you can see, it is very difficult to give a implant in a patient who doesn't have a height. So what people are doing, that they are putting a fibula over the marginal and then using a implant. But I think it is a overkill to do both the procedures. And so you have to select a patient again properly. Maybe a candidate who doesn't require a radiotherapy is a patient where you can put this long implants, and long implants also can give you a pathological fractures, because if you can see, it is just reaching till the lower cortex. So you have to be very careful when you are selecting a patient who is not going to receive radiotherapy. Maybe that candidate I will choose for the primary implant, or maybe a fibula along with the marginal will be a choice to do a routine implant, what we do it. And that's how I think MSKCC people are doing a fibula over the marginal mandibulectomy. But we don't have much of, I don't have much of experience